Hello, and welcome to Mucin-deficient dry eye and its complications for contact lens wear. My name is Nitya Murthy, and I'm an optometrist at Indiana University School of Optometry. Thank you for joining us. I hope you've been enjoying the rest of the conference. I hope you've heard and learned some interesting things, and I thank you again for your time with us this evening. So when we start talking about dry eye, we first talk about what's there left to talk about. It seems like it's a major topic of conversation in all our conferences. We see it all the time in our clinics, and we talk about it with our colleagues all the time. And really for good reason, because 16 million Americans continue to be symptomatic of dry eye disease. And we've had great progression in the field, some really compelling research that has helped us understand that really important relationship between vision and comfort for our contact lens patients. But even so, even though we have these great tools, we have thermal pulsation now, we understand cleaning the lashes with microblepharotic exfoliation, we understand that artificial tears can be a good ancillary tool, warm compresses, nutraceuticals. We really have a big armamentarium of tools now that we can use to treat these patients. Even so, more than 70% of doctors say that over half their patients continue to have signs and symptoms of dry eye disease. So, with all the different treatment options that we can now offer to our patients, we have to wonder, is there a missing piece to the puzzle? Is there something that we haven't quite unlocked that continues to prolong these patients' signs and symptoms? So on this slide, we have a really great definition. It's the Duster definition, and I like it quite a bit. And the reason I like it is because it talks about the complexity and the depth of dry eye disease. We now know that it's not as simple as their eyes are dry, let's get them wet with artificial tears. We know that there's a lot more to it than that. The things that I want to highlight from this definition is tear film instability. That's going to be the most pertinent to what we talk about today as we march through the 3 layers of the tear film and make sure that we have tools and a plan to address stabilizing each layer of the tear film. When we treat dry eye disease by treating the root causes, that's when we have the most success. If we do a catch-all treatment saying, the last 5 or 6 patients that I saw this afternoon all had dry eye, here's what I did for them, it works for most people, go home and just try this, and this, without really assigning each treatment to a cause. That's when we have some errors in treatment and we end up prolonging these patients' symptoms, and we keep them from having that contact lens comfort that they are seeking. Mucin deficiency is one of those things that is often missed. The hallmark sign of mucin deficiency is conch staining, and we'll talk about that at depth throughout the course of this talk today. But when we see conch staining or when we see other signs of mucin deficiency and we don't treat it, that's when we continue to have subjects and patients that just don't feel comfortable in their lenses. So let's first talk about the other types of dry eye first. Evaporative dry eye gets a lot of attention, and that's with good reason. Over 80% of dry eye cases have an evaporative component to it. So that's our MGD, and we see it all the time with people's contact lens wear, with screen time. It's very common, very prevalent, and now we have some really good tools for treating it. IPL works really well. All of the thermal pulsation, so that's your lipoflows, iLuxes, all of that works really well. We know that nutraceuticals, omega-3 supplements really help. We know that blink exercises can help, warm compresses. So in that table we have kind of, and it's by no means comprehensive, but we have a reasonable summary of all the different treatments that we have for evaporative dry eye. Over to the right, we have aqueous deficient dry eye. Now that's more commonly associated with things like Sjogren's disease, autoimmune conditions, and things like that. Those treatments are a little bit different. We have things to just increase the tear volume, really. So that's punctal plugs, autologous serum. Sometimes scleral lenses can help as well. Amniotic membranes, all those things that really help the cornea. That's what we use the most for aqueous deficient dry eye. I like putting the different treatments in these 2 columns in the tables because it helps us know for sure that when we see a cause, we're going to identify, understand where that's coming from, and then treat it appropriately. We know that we can't use the same treatment for both types, and we know that we need to have kind of focused treatment when we start talking about dissecting their causes. And that takes us right into the third form of dry eye, which is mucin deficiency. Now, that's often lumped together with aqueous deficiency, but for the purposes of this talk, we need to separate it. Reason being that it has its own treatments, and we'll go through that in a couple slides. So first, what is MDDE? As we all know, mucins are secreted by goblet cells in the cornea and conjunctiva. When there's a decrease in the density of goblet cells, that's when we have MDDE. This is common in Sjogren's syndrome. It's common in a lot of autoimmune conditions, and it's also common in contact lens wear. The etiology of MDDE is that, like we said a couple minutes ago, when the conjunctival goblet cells are stretched out and when there's flattening of the epithelial cells, they lose their functionality and they stop producing this very important mucin, MUC5AC mucin that's very common in the tear film. When that happens, that's when you have, I'm sorry about that, let's switch back here, make sure this is looking good. Yep, so when we have that happen, that's when we are lacking this layer of the tear film, and that causes a decrease in the adhesion of the tear film between the evaporative and aqueous layers. Where this fits in on this chart, and this is again from the DUCE report, is it's kind of towards the bottom in that mixed area. So we have the evaporative dry eye, we have the aqueous deficient dry eye, and somewhere in the middle in that mixed area, that's where our mucin deficiency fits in. It is its own entity, and it needs to be treated as such as well. But it has a lot of similar symptoms and signs from these two other types. And we need to be able to tease out when it's which type. So how do we diagnose it? Conjunctival staining is the key to diagnosing mucin-deficient dry eye. When you see conj staining, there's a few different causes to it. So we know that conj staining can just happen from contact lens wear, but that's really more of an indentation. So the edge landing on the conjunctiva can cause that ring of indentation. And that's not true conj staining, that's just from having a lens in the eye. When patients remove the lens, that can also cause an area of staining depending on how they're doing it. Oftentimes inferiorly on the conj you'll see a blotchy spot of staining, and that's not true staining either. But when you see the kind of small specks of staining on the nasolatemporal sides, that's really true conj staining, especially if you see it before contact lenses are inserted. And you see it more so in the mornings. So it's a good idea to bring these patients in the mornings to check on them. So when you evaluate the conjunctiva, you have to make sure that you're having the patients look in all the extreme phases. You have to have them look up and down and left and right, up and to the left, up and to the right, all of the extreme gazes so that you can really, really have the conjunctiva stretched so you can look and see what's going on. When there's asymmetric staining between the nasal and temporal sides of the conj, that's a good indication that there's some mucin deficiency going on. Because if it was truly lens related, most of the time it's more or less symmetrical around the limbus where the lens lands. Another thing that you'll see in MDDE is corneal staining. Now, of course, you see that in aqueous deficiency as well, but when you see a kind of patchy staining pattern, that's a sign of MDDE as well. So it looks, it's most often located inferiorly. You'll see corneal staining. And if you see a patchy staining along with conj staining, those are two great indicators that we have a mucin deficiency component here. Last is filaments, and that I think we're all more familiar with. That's a more severe cause or form of MDDE. Filamentary keratitis is a tough condition for folks, especially contact lens wearers, and that's treated a little bit differently than what we're talking about here. So how can we treat it? The best ways to treat MDDE is with vitamin A ointment. So I really like using Ocunox ointment, and I like using it because it's preservative-free and it works really well. So the big thing with using this ointment is less is more. Reason being that it's really quite a viscous ointment, and getting too much into the patients will just blink it out. So putting a tiny bit of the ointment in at night in the lower eyelid right before they go to sleep will really do wonders and really help patients that are suffering from conjunctival staining. Other things that will help would be cyclosporin, so that's your Restasis and your Cequa. Studies have shown that the mechanism of action for cyclosporin works really well on the conjunctiva, and it improves the goblet cell density. So that's a great way to treat it, because you'd be helping get their tear volumes back up anyway. Acetylcysteine really works, and that works better for filaments, a more severe form of dry eye. Autologous serum really helps. Fluorometholone really helps. So Flarex is a great drop to use in patients with corneal and conj staining, because you'll be helping their corneal staining by using a good corticosteroid drop, and you'll help their conj staining. Studies have shown that more than the other ocular corticosteroids, fluorometholone has great penetration in the conjunctiva. So that's a good one to reach for, and I like using Flarex when we're able to get that for the patient. And amniotic membranes do a good job as well. So amniotic membranes do cover the cornea, of course, but they reach out over the limbus. And we've talked to our reps about it, and they've talked about how the effects of having the amniotic membrane in the eye can actually help the conjunctiva, even though it's not covering the whole area of the conjunctiva. So that's a great place to get started if you see, especially, even moderate corneal staining, because you might as well, fix all that up, help the conj, and then go forwards with the rest of your treatment. This is called the hydra problem, and what that is if we don't treat all our forms of dry eye concurrently, one that we've not treated is going to become the prominent cause of dry eye. So we've talked about mucin deficiency, we talked about how to treat it, what it is, how to spot it, how to treat it, and what to do. But the question is, why would we do something about it if we've been doing these other things and most people are happy? Well, the reason is because, like our DUCE-2 definition tells us, dry eye syndrome is a multifactorial condition. So if we don't treat every cause of it, and if a patient has mucin deficiency and we're not treating it, they'll continue to have these symptoms. And to patients, it'll just feel like they're not comfortable, that they don't want to wear their lenses. They're not really going to have the nuanced understanding that we have, saying, well, the doctor did help me with my evaporative component, and the doctor did help me with my blepharitis, but I understand that this is why I'm not comfortable. They're just going to feel like the things that we tried didn't really work, and that's going to lead to dropout. So, just like with the hydra, you can't just chop off a couple heads because more will grow in its place. We have to make sure that we're just going ahead and hitting all of our causes at the same time. So what can we do for our contact lens patients? Now that we have a plan for how to treat mucin deficiency, we build that into our contact lens dry eye treatment plan. So if MDD is present, start the patients on a vitamin A ointment. It's easy to use, it's readily available, fairly cheap, and just a little bit of it can go a long way. And it can be used long-term because it's preservative-free. Using cyclosporin concurrently can do great things as well. Many of us put our patients on Restasis or Cequa anyway, so if the patient is able to get it and tolerate it and things like that, using that concurrently will help the cornea, it'll help the conj, and it'll help just improve their tear layer. Let's go back up here, sorry about that. We have to make sure that we're looking at our contact lenses carefully in these patients. So if you see deposits, mucin deposits on the lenses, then that's a sign that we have MDD that's not been resolved. Looking at these lenses, especially in the morning, is when we can spot these mucin deposits if they're going to show up throughout the day. If you see these deposits, one, we treat the MDD, but two, we switch them to daily disposables. And there's a lot of good reasons to use daily disposables, but this is definitely one of them, to make sure that the lenses are not accumulating these deposits day after day. The other thing is we have to make sure we've fully rehabilitated these patients before we put them back in their lenses. I think as providers, we want to make our patients happy and get them back in lenses sooner rather than later, but we just can't do that with this form of dry eye. We have to make sure that all the staining has been resolved before we let them assume full-time wear. Now, if there's like a special occasion or something, it's reasonable, depending on the case, to get them back in for shorter periods of time. But before they are let loose to wear contact lenses for their full amount, we have to make sure that we've really adequately treated the cornea and the conjunctiva and made sure that the eye is looking healthy and happy and quiet before we let them get challenged by contact lens again. And in severe cases, if the patient's wearing scleral lenses, it's reasonable to put autologous serum tears or hyaluronic acid in the bowl. That will really help soothe the cornea as well. So here we have our case. We have a couple cases. We'll see if we have time to go through both of them. But this is a patient that I saw a few months ago. She was a 31-year-old white female. She came in complaining of just contact lens discomfort. She kind of had these general abstract symptoms. She was an office manager, so she was spending a lot of time on the computer. She was telling me that her contact lenses just didn't feel very comfortable. She had previously been put on Bruder masks, just said that didn't really help very much. And she used artificial tears about 6 to 8 times a day. So that was really quite high. She wore Acuvue Oasis lenses. And her prescription's listed on the screen. So as an Acuvue Oasis wearer, she was replacing her lenses every month because that's what these patients all think that they need to be doing. Her average wear time was really quite high, and she was cleaning her lenses with OptiFreeze solution. She reported she didn't sleep in them overnight, but she napped in them and showered in them. So we already have some, red flags digging around here. The contact lens hygiene is a problem. The wear time is a problem. So we have some things to think about already. But here's our exam findings. So she had grade 1 Demodex blepharitis in both eyes. She had eyelid margin erythema and 1 to 2 telangiectasia in both eyes. We did meibomian gland imaging, and she had that kind of characteristic arcuate pattern of meibomian gland truncation that we see all the time in our contact lens wearers. And she had been wearing contact lenses for about 10 years, so no surprise there. We had conj injection, we had conj staining, but we'll come back to that. We had corneal staining, and we'll come back to that as well. We had low tear volumes, low T-buds. We looked at corneal nerve sensitivity. It was decreased in both eyes. And we did the Korp-Blackie illumination test. And she had complete eyelid closure in both eyes. So that was fine. But going back to our staining, that was really some severe conj staining. And it was not symmetric between the nasal and temporal regions. So that was a big indicator of mucin deficiency. That combined with that patchy inferior corneal staining was the clue that we had to treat this as well. So kind of going through it just top to bottom. For her lids and lashes, we suggested IPL, and we recommend 3 sessions in our clinic, with the 4th session if needed, all separated by 2 weeks apart. So the IPL would have done, was designed to help her with her telangiectasia with the Demodex, and it would have helped her meibomian glands as well. Looking at the corneal staining, that was a little too much for just an ointment. So I recommended Flarex to be used 3 times a day for 2 weeks, and then 2 times a day for 2 weeks after that, with the plan that I was going to see her 1 month after her second IPL treatment. So 2-week IPL treatment, then 4-week IPL treatment, just to check in and see how she was doing. And then for the conj staining, I did put her on Ocunox ointment. I gave her the same instructions we talked about earlier, just a very little bit of it, lower eyelid, at night with your contact lenses out before you go to sleep, and just close your eyes and rest. And by morning, it's all usually absorbed pretty well. So when she came back in a month, she was doing a whole lot better. So I think the combination of the IPL, the corticosteroid and ointment was having her feeling loads better. When I looked at her and I stained, she did have some corneal staining still, mostly inferior, And she had some conch staining, but it had come down to grade 1, and it was much more symmetric. So with that being the case, I felt comfortable in letting her wear contact lenses part-time, still not full-time, because we still had one more IPL session to go. And we sent her back, and I'm going to be seeing her in about 2 months. So with that, she did really well because we treated all the forms of dry eye concurrently. We didn't say, here's this, try this, come back, see how it works. It was really us taking a very authoritative role in her treatment, saying, you have all of these things going on. We're going to treat all of them. We won't let anything go by unaddressed. So she did great. I think we're short on time, so we can briefly summarize this case. But this is one of those cases in which she said she had been to 3 other eye doctors and nothing helped. So that was an indication to me that if 3 other docs had failed before me, I most likely would have been the 4th. So we talked a little bit about what was going on. She had tried a whole lot of different things. 53-year-old white female. She had some hypothyroidism, glaucoma suspect, early RA. She had tried Xiidra, Bruder mask. She was on nutraceuticals. She was using Lotamax already on a pulse dosage as well as twice a day. So she was using it for flare-ups more than twice a day whenever she needed, as per her last doctor. And she was doing lid scrubs. And she reported that she was just always uncomfortable, that she really had just this extreme discomfort, and she was not able to, do her activities of daily living comfortably. These were her exam findings. She was doing a good job with her lid hygiene because there was really just trace blepharitis. She had eyelid margin or erythema, most likely from scrubbing so hard, because this was one of those good patients that's really trying her best. And she had some grade 1 telangiectasia, meibomian gland dropout. Given her age and things like that, it was reasonable. Conch injection, conch staining, corneal staining, low tear volume, hypersensitivity of the corneal nerves, which we see sometimes in these cases as well, and incomplete eyelid closure. So again, a lot of different things going on, and the plan was to just treat all of it. So we still recommended IPL to calm down the eyelid margins, to help with the meibomian gland rejuvenation, and to get rid of that, some of that persistent blepharitis that she wasn't quite able to get. For her conch staining and her corneal staining, she was on Lotamax, which I took her off of and I replaced with Flarex. Lotamax SM is a great drop, works really well, but where she had conch staining that I wanted addressed as well, I put her on Flarex, with the goal that it would help with both. I put her on Ocunox ointment in this case as well, which is fine, preservative free. We can use it long term, so that's a good option for her. I thought about punctal plugs, but I didn't at that visit to see how she would do with these other things first, and also because we're doing IPL. And then for her eyelid closure, we recommended some type of night seal goggles, or just sleeping with the Bruder mask on her eyes to help with the weight to close the eyelids better at night. So she came back about a month later after her second IPL treatment, and she was also doing a whole lot better, and she loved the ointment. She said that was the one thing that had helped the most, that she had not tried before, and that made a big difference for her, and it made her feel comfortable for most of the day, and she was getting symptomatic towards the end. So this just goes to show that there's really a lot to do in dry eye. It's never simple, and it's never something that we can take for granted. We have to understand the root causes and treat all of them concurrently for the most success. And when we have mucin deficiency, we need to understand what it is, where it comes from, how to treat it. So if you have any questions, please feel free to email me. My email's listed on the screen. And thank you again for your time this evening.